Welcome everyone. My name is Becky Sanders. I'm the Program Director for the Upper Midwest Telehealth Resource Center. Thanks for joining us today. We are in all attendees are in listen-only mode. We will be recording today's session and posting both the recording and the slides to our website under archived webinars on the UMTRC.org website. You will receive an email when that information is posted to the website. We will stop at the end for questions, and you can enter questions in the Q&A function at the bottom of your screen. Please only use the chat if you have a technical issue. Thank you for joining us today, and now I'm happy to introduce Luke Worley, Program Coordinator of the Upper Midwest Telehealth Resource Center to you. If you have sent in an email on our website, or called our 800 number, it is probably Luke that has helped you. So he is going to talk about some of the basics of Telemedicine 101 or Telehealth 101 and some of the more frequently asked questions that he has received in the last couple of months. Thanks, Luke.
Thank you, Becky. As she said, I'm the Program Coordinator of the Upper Midwest Telehealth Resource Center, which means I'm the first point of contact for most of the technical assistance that comes in either through the telephone 800 number, email, or through a website form at the National Center, or even through our website. So I'm going to begin today. We just done our introductions, and then I'm going to give you a little bit of an introduction into what we do here at the UMTRC, what our scope of work is, and how we fit into the national landscape. Then I'll transition to federal guidelines, specifically for Medicare billing, and kind of how telemedicine works at large. Then I'll give some region-specific information for our 4 states of Illinois, Indiana, Michigan, and Ohio. I'm going to cover the reimbursement guidelines that are sort of more generally applicable, especially in a pre-public health emergency world. And then I will share some trends in technical assistance along with some links to useful resources that we have curated, both content that we've homegrown here among our staff, as well as things that we've collected and collated from other resource centers within the national consortium and other entities across the country. Then we'll leave some room for question and answer if we have any, and then we'll go ahead and give you back your day. So I wanted to first introduce the National Consortium of Telehealth Resource Centers, which is the 12, which is comprised of the 12 regional telehealth resource centers, of which we are one, and then 2 national resource centers, the National Telehealth Technology Assessment Resource Center and the Center for Connected Health Policy, which is housed at our National Policy Research and Research Resource Center. So I'm going to be referencing both of those national centers here in a little bit, as we get a lot of questions about technology as well as policy and compliance from a federal level. If you want to visit that website and have any interest in any other areas in the country, or just kind of want to keep up with what the National Consortium is doing, the link to that is below this image. So what we do as far as our scope of work, I think it's aptly coined virtual librarians by Becky. Basically, our scope of work includes technical assistance in the areas of telehealth adoption, policy and regulatory updates, compliance, help with reimbursement, billing and coding, and then being a convener to be able to connect people to other programs and other HRSA or HHS grantees. And then the other part of what we do are these presentations and trainings and outreach activities, which involve specifically distance learning or sometimes face-to-face education, in the form of our annual conference. So that's kind of what we do. We are not a telemedicine clinical service provider, and nor are we a technology we cannot recommend other specific technologies. We do not deal specifically with any technological solutions, but I will get into that in a little bit. You can also visit our website down here or connect with us on Facebook and LinkedIn. Just search Upper Midwest Telehealth Resource Center or UMTRC. So it is a 101, so I think one of the best ways to start is basic definitions. So telehealth and telemedicine have sometimes been used interchangeably throughout the years, but as telehealth becomes a more popular and widely adopted concept, I think it's important to distinguish between the two terms. Telehealth is the all-encompassing umbrella term, this green circle here in the Venn diagram, for anything related to distance health activities and clinical remote monitoring, or really even anything related to like e-visits or that kind of thing. Telemedicine is the actual clinical encounter that takes place between a provider and a patient. So when you're drafting any kind of memo or brief or anything like that, it's important to note the difference between those two terms. There are two types of telemedicine, asynchronous and synchronous. Asynchronous describes a store and forward model, which is basically usually imaging of some sort that is captured at a distant site and then forwarded to a provider who then takes a look at it and then reports back to the patient. This is an extremely cost-effective and quick way to engage in telemedicine, but obviously one of the barriers is that reimbursement is limited. So the most common form and most widely reimbursable form is synchronous delivery, which is kind of like what we're doing right here. Face-to-face, live, interactive video and audio connections. It has to be on encrypted software so that it's HIPAA compliant, and it has to be real time, or like what we like to call live and interactive. There's another sort of subcategory of telemedicine called remote patient monitoring, but we're not really going to get into that at the moment unless there's a question at the end. So like I was talking about earlier, telehealth itself is not a service. Telehealth is a delivery mechanism. Telemedicine would be the actual clinical encounter. Okay, so I just want to make sure that we reiterate that. And I have been using face-to-face a little bit incorrectly, so I have to correct myself even on this one a little bit. Instead of using face-to-face, which we are face-to-face technically here on this Zoom call, we should be saying that it is a substitute as a delivery mechanism to in-person care, okay? So now that we're done with definitions and concepts, it's time to get into what exactly what are sort of the modalities of telehealth and telemedicine encounters. So telehealth initially began up in the Northeast in the Boston area as a way for specialists to be consulted on the phone right there in an emergent care department. Somebody comes in presenting with a particular issue. They don't have a specialist nearby right away. So the idea was, well, why don't we just have somebody be able to consult with us while the attending physician is right there next to the patient's bed, rather than having to call somebody in or move the patient or something like that, which sort of became the root, and all of these other branches sprouted from it, which is the idea of integrated care, where you can have mental health services in a primary care setting. You can use it to manage chronic conditions. We're talking, diabetes self-management training and that sort of thing. And one of the things that's really picked up lately is for primary and behavioral health care in schools, so that you can cut down on the amount of time missed in terms of the student's day, but also the guardians or the family members' workday, from having to take off, come get them, drive them to a clinical setting, potentially wait in the waiting room. And overall, the idea of telehealth is to try to increase access to care and decrease inefficiencies within the healthcare system. So obviously, amid the public health emergency and the outbreak of COVID-19, interest in telehealth has increased dramatically as we're trying to decrease in-person visits to limit contact as much as humanly possible. We have been pretty diligent in collecting state-specific and federal resources throughout this pandemic, including policy briefs and updates on executive orders from governor's offices, and new billing guidances from departments of health and human services, from family services and family and social services administrations throughout all 4 of our states. And you can find all of that information at this link right here. So before I move on, I'm just going to go ahead and pause. And I know that I have a propensity sometimes to talk a little quickly. So I wanted to check with all of the observers that everybody's following along and we are in a good spot.
I don't see any questions.
Great. Okay, I'm going to try to be more cognizant of the speed of my voice from now on. So as far as a federal policy goes, telehealth and telemedicine is regulated almost exclusively through CMS. So the Center for Medicare and Medicaid Services treats telehealth and telemedicine differently on a federal and state level. So professionals are regulated at the state level through either the Office of Medicaid or through a private payer or through the state legislature. There's all kinds of restrictions and policies that, as of right now, are not currently being enacted. But it's important to know that as we near the opening up of the rest of the country through various stages that have been dictated by gubernatorial offices, that all of this is, what I'm presenting here was before the public health emergency, and I'll get into some of the changes that have occurred as a result of the public health emergency. So Medicare pays for outpatient professional services for patients in rural counties and health professional shortage areas in rural census tracts among urban and other metropolitan areas. So basically what that means is that in order for Medicare to reimburse for telehealth, the patient must be located in a health professional shortage area or in a rural county. Those regulations have been lifted. We do not know when that is going to expire or if it's going to stay in some capacity. So I'm not sure if that was one of your questions you were having at the very beginning. I'm not sure how to answer it. I'm just going to go ahead and head that one off at the pass. And Medicaid is obviously regulated at the state level. So there's no federal requirement that Medicaid must reimburse for telemedicine encounters at this particular level. But it is important to note that as of spring 2019, all 50 states and Washington, D.C. do cover live and interactive telemedicine. And obviously throughout this public health emergency, most state Medicaid programs have expanded their coverage dramatically. So normal telehealth reimbursement requirements for Medicare, just to reiterate, is that the patient outside of a metropolitan statistical area in a designated originating site, so the originating site being the place where the patient is actually located. And up until very recently, because of the public health emergency, that could not be a patient's home, right? It had to be in a particular designated originating site as dictated by Medicare. And then the service rendered had to be within the CPT code range, which you can find in the Medicare Learning Network Handbook, which I will link to later on in this presentation. And then eligible practitioners had to be the ones that delivered the care at an eligible distant site, which is where the provider is located. Right now, the patient being outside of a metropolitan statistical area and being in a designated originating site has been waived. So patients are eligible to receive services within the CPT code range, but they can be in a metropolitan statistical area and they can be in their home. And these CPT code ranges have broadened dramatically during the national pandemic. So what is an HPSA? So an HPSA stands for Health Professional Shortage Area, and these are in the areas of primary care, mental and behavioral healthcare, and dental. And overwhelming majority of these tend to be located in rural census tracts of metropolitan statistical areas or in entirely rural counties. Okay? In order for you to find out whether or not you are in a designated professional shortage area or in a rural county, you can just use this eligibility lookup tool from the Health Resources and Services Administration, which is a division of Health and Human Services, and consequently also our funding mechanism. Obviously, this, just to reiterate one more time, this is not applicable as far as the national health, public health emergency is concerned. So I referenced this earlier, the Medicare Learning Network telehealth fact sheet. This gives you a pretty good and extensive list of CPT codes, as well as the ranges of those particular services. So if you want that information, this is published every single year, and it varies between a dozen and 15 pages or so, and it gives you a good little description of the service as well as the relevant CPT code. Maybe at the end, if we have enough time, we can get into any modifiers or billing or that kind of thing. But as of right now, I'm going to go ahead and keep moving on. So this is kind of the standard model of telemedicine billing for Medicare. The patient is in a rural originating site. These can be called the spoke site or the patient site. They bill Part B of the facility fee through CMS, which goes to the distance site provider or the provider site, or sometimes known as the hub site, generally in a larger metropolitan statistical area with a large hospital system. And they bill Medicare Part B for their professional fee. And that's how the encounter is actually billed. And here are those codes right here. Normal CPT code with the appropriate modifier, and then the facility fee is the Q3014. As of right now, obviously we know that that is not in effect. So it looks like we're getting a few questions here. What if you are not located in a shortage area or rural area, but you service a shortage area, rural area for telehealth? Will your service be covered? Yes, as the distance site provider, I would believe that you would still be covered if the patient is at a valid originating site. That's always been kind of the big hang up. And obviously, as of right now, all of those requirements have been waived, and pretty much everybody from Medicare to Medicaid and private payer have decided to reimburse regardless of the patient's location. I think that, Becky, do you have anything to add to that question?
No, I agree with what you said. It really depends on where the patient is for that originating site, not where the provider's at.
Yeah, and fingers crossed that we start to accept that the reality of telehealth and telemedicine is that its strength is to be nimble, and so that hopefully we start to see that those originating site rules stay relaxed up to a certain capacity. Whatever is negotiable at the federal level. We're going to continue to keep our finger on the pulse of that and let you know. So I'm going to move away from the federal level, and I'm going to start talking a little bit more about each of our 4 states here. So we'll begin with Illinois. So Illinois Medicaid reimburses for live video telemedicine, which is what I referenced earlier, which is that synchronous delivery where you have a live audio visual connection for telepsychiatry and certain primary care and you would follow the exact same standard model that we listed earlier. For Medicaid, they use the GT modifier versus telepsychiatry. There's not a whole lot of language, unfortunately, in the Illinois Administrative Code when it comes to store and forward or asynchronous telemedicine. So unfortunately, I don't really have a whole lot to give you on that particular front. I just saw another question pop up. Can we bill for new patients using telehealth, or do they have to be seen in the office first? we are a specialty office and it's hard to decipher what we are able to do. Good question. So normally a lot of payers will only reimburse for telehealth and telemedicine for established patients, meaning that you have seen them in the office and obtained some kind of consent. During the public health emergency, however, new patients are eligible to be seen through those relevant CPT codes, but you must get consent and document it first. And it functions just like you would getting consent in the office. So it's yearly. Again, after this is all over, it's hard to tell exactly what's going to happen. We're hopeful that at least, there can be some kind of compromise, maybe something like, you can see new patients, but only if they're located within a certain, mile radius or something. It would be nice to know something from the federal level, but we're just not entirely sure yet. Becky, do you have anything to add to that?
Nope, totally agree.
Great. So, and in Illinois, there is, well, as in all of our states, there is some kind of parity language, but as of right now, May 27th, 2020, in Illinois, commercial or private payers are not required to cover telehealth services, but certain plans absolutely do reimburse for it. And again, amidst the COVID-19 outbreak, a lot of commercial and private payers are reimbursing comparable to Medicaid and Medicare. So we'll move on to our next state, Indiana. So Indiana reimburses, again, for live and interactive telemedicine, but Indiana has specific language that it does not reimburse for store and forward telemedicine. And the originating site, meaning where the patient is, must obtain the patient consent and then maintained and documented at both the distant and originating sites. So what that functionally means is that if you're seeing a patient for the first time via live and interactive telemedicine, you're probably going to have to send them via email a copy of your consent form or have them read it directly here on the screen, document that consent, and keep it on file in their electronic medical record. So yeah, like I said, the provider-patient relationship can be created through the first telemedicine visit, which is subject to all clinical standards of care. And I'm going to go ahead and just pause there to say that I'm going to reference later another webinar that we just did last week on documentation and consent for all 4 of our states. So we'll get into that in a little bit. When it comes to issuing prescriptions for telepharmacy, the patient and provider must be an established relationship before issuing any kind of prescriptions. And issuing of controlled substance prescriptions are also subject to that particular provider being waivered by the DEA. There is a parity rule in Indiana, meaning that a policy must provide coverage for telemedicine services for the same healthcare delivered in person. So basically meaning that if there's a way for telemedicine, for a telemedicine encounter to replicate in-person care, then a policy must provide comparable coverage and reimbursement. So therefore, it can't be at a lesser rate just because they're seeing somebody digitally. This was a new section of Indiana health coverage programs policy that was effective on the 1st of this year, which included a few new procedural codes, and you can check those out at this particular link here, which will send you to the actual Indiana Medicaid source material. So Michigan, much like the rest of our region, reimburses for live and interactive telemedicine for audiovisual encounters for certain healthcare professionals, and they have their own rules for originating sites and specific services. They also do not reimburse for store and forward or remote patient monitoring. We talked about consent just a little bit. And regarding prescriptions, the professional providing the telehealth service has to meet the following criteria: that the health professional is a prescriber acting in the scope of their practice, that the health professional is prescribing a controlled substance, they must meet the requirements of the Ryan-Haight Act, and they are also subject to DEA waivers. And as far as commercial and private payers, insurers cannot require face-to-face contact between a healthcare professional and a patient for services appropriately provided through telemedicine. So it's a little bit different language, but functionally it means pretty similar. It's in accordance similar to what Indiana has. Ohio has reimbursement for live and interactive telemedicine via synchronous audiovisual software. They do not reimburse for store and forward or remote patient monitoring either. So when it comes to originating sites, Ohio has basically said that the following are all valid originating sites. So that includes the patient home. And we'll see if the rest of the states follow suit, especially after this public health emergency designation is lifted. So there are a couple excluded places of service though. Any kind of correctional facility or institution, meaning a jail or a prison, is not a valid place of service. So then when it comes to commercial and private payers, I just got a question about this yesterday. Ohio does have a law on the books, but it doesn't take effect until the 1st of next year, which will actually require a health benefit plan to provide coverage for telemedicine services on the same basis as in-person plan coverage would. So that's kind of a brief overview of the 4 states. Each slide here also has a link to the reimbursement summary that we curate on our website and update at least annually, but if there's ever any kind of sweeping change like Ohio has made in the last 18 months, then we go ahead and do that live. And then finally, I want to go ahead and shout out our friends at the National Telehealth Policy Resource Center. They house the Center for Connected Health Policy, and they have a searchable database as well as a really user-friendly interface that gets you up-to-date coverage of national and state-level policies. So I highly encourage you to use that resource. So then finally, if you have a patient who is dual eligible for Medicare and Medicaid, you always bill Medicare first. If that claim is denied, then it is automatically sent to Medicaid. Medicaid obviously uses a bit of a different CPT code, or if they do. And then if Medicaid also denies the service, based on the fact that Medicare was not billed first, you can always resubmit the claim to Medicaid. So that's how it's billed, at least generally. Like I said, everything is sort of in flux now as some states are opening up, some states aren't. Some people are asking us what's going to happen, but we're not entirely sure. The only thing that we can tell you is that as far as we're concerned, we're meeting our ultimate goal here at the UMTRC and as advocates for telehealth and telemedicine, which really is to increase access to care. So I'm going to put a pin in that and ask if there are any Q&A, if we can answer anything before I get into some of the trends that I've seen since March 1st.
I don't see any additional questions at this time.
Great. So obviously, since the declaration of the public health emergency, the interest in telehealth has risen precipitously. We've fulfilled more technical assistance requests than we ever have before in the same time frame since the first of the year up to the present. And some of the things that continually keep popping up include getting started, meaning like, I don't even know how to adopt telemedicine as a billable service encounter. So where do I even begin when it comes to talking about telehealth as a delivery mechanism? And then a lot of people are asking, well, we normally would do this in the office, but how do we document and get consent when the patient can't see us in person? We get a lot of requests for, well, I'm interested in this. I'm wanting to train my providers and my clinical staff on this technology, but I don't know what to use. And then we get a bunch of questions, or at least we did in the month of April before CMS revised their list of codes. How do we reimburse? How do we bill Medicare for services when our patient has a flip phone and has no Wi-Fi? You know, how do we see them, and how do we get reimbursed because live and interactive audiovisual is not an option? And then finally, well, I've got all this stuff set up. I've read your website. I love what I see. This all makes sense to me. But what does an actual clinical encounter look like when it comes to telemedicine? How do I get vitals? What's the patient's responsibility? How do I document what actually happened? That kind of thing. So when it comes to getting started, I just wanted to share with you these 3 resources. We have a whole getting started guide, which we've collated over the span of several years, which includes telehealth training modules on YouTube. It includes other templates and forms that can help you write a business plan or a proposal, to actually starting to write a work plan for that kind of thing. You may also just want to check out our frequently asked questions. They're usually quite short and generally answer a lot of those getting started questions. And then finally, we're not a granting agency, so we don't give out startup capital, but the way we got our funding was by looking at grants.gov, searching telehealth, and then writing for one of those programs. When it comes to consent and documentation, I would recommend going to our archived webinars page and looking at the slide deck or watching the recording, or both, from either May 21st or April 14th. And those slides have citations from all 4 states' administrative code on what constitutes informed consent, what are the documentation standards, and even some when it comes to standards of care. So if you're hung up on consent and documentation, that's definitely one of your best resources, because you can actually find the specific language referenced in those slides. I saw a question pop up. If the call is initiated by an established patient and a nurse practitioner assesses the patient's complaint and determines a procedure is required, can this be submitted for reimbursement if the procedure is scheduled within 7 days? You know, I think I'm going to have to defer to Becky on this one. I'm not exactly sure.
Yeah, this is a good one, Mary. And my question is, what CPT code would you bill this under? And is your call an actual, is a telephone call, or is it a virtual visit with video, audio on both sides? Because I could answer either way. If it's a phone call and you try and bill it as a virtual check-in code G2010 or 2012, then then there is a procedure in the next 7 days, then the answer is no. But if it's an audio visual or even an audio only now with the latest changes, normal scheduled virtual visit, it's a telemedicine visit, and you use, and I'm blanking on whatever the normal office visit code is, and you schedule it and bill the office visit code, and then you have a follow-up, then yes, it could be submitted for reimbursement. I hope that makes sense.
Thanks, Becky. The other thing that I wanted to provide on this particular webinar is a link to a one-page informed consent for telehealth consultation. You have a couple options here when it comes to obtaining telehealth consent. If you already have a consent form that you're comfortable with, that patients are also familiar with, I would consider maybe just adding an addendum that includes consent to telehealth documentation or telehealth consultation, and be sure that the patient is informed that that addendum has been added. Or if you really just want to make sure that you're dotting all your I's and crossing your T's, you can have them sign this separate form, which I said again is 1 page. That can be emailed as a PDF, or you can simply have it up on the screen like I'm doing here with these slides, and walk the patient through each of the stipulations and get consent that way. Just as long as you're documenting that, yes, we've informed the patient that they are consenting to participate in a telehealth consultation. So when it comes to technology, like I said earlier, as a federally funded entity, we have to be vendor neutral. The only way that we could recommend something is if we could provide a completely exhaustive list of every single technology solution out there, which is of course well beyond our scope of work and also nearly impossible. So we have to basically say we don't do warm handoffs, we don't recommend particular technology providers, but the National Telehealth Technology Assessment Resource Center does have some technology toolkits in the areas of all kinds of software, hardware. You know, basically it gives you the end user the opportunity to assess your own needs, and then use them as a resource to figure out what exactly best fits your practice. And for the latest information on HIPAA compliance, I would suggest visiting HHS, as they have a section there that's specifically geared toward professional providers. It's well up to date, and they even give a certain number of platforms that they recognize as encrypted sufficiently to be HIPAA compliant. So I mentioned earlier that normally Medicare is only reimbursing for claims that have taken place after a two-way audio-visual encrypted connection. As of April 30th, I think because of so many providers being so frustrated that they were unable to bill for services that they had rendered to their elderly patients who didn't have sufficient internet access, or some other potentially, you know, maybe home insecure or lower income patients who couldn't have a stable internet connection, that they needed something to reimburse for audio only. And so CMS, if you click this link, it takes you to CMS's website, and they actually have a downloadable zip file which has 2 Excel spreadsheets in it, and in there there's actually a column that says eligible for audio only visit, yes or no, and you can find that information right there. When it comes to mapping a clinical workflow, the National Consortium of Telehealth Resource Centers, our umbrella organization, did an excellent video just a couple years ago, and Rural Health Information Hub actually grabbed that, as well as a couple other resources, and you can find that right here. It should give you a good overview of how an actual telemedicine encounter works, and give you recommendations for best practices in terms of integrating it into your own clinical workflow. And then we have started to collate some patient and provider-centered resources. Most of these are COVID-19 specific, but because of the COVID-19 outbreak, HRSA has sent out funds to all of the telehealth resource centers with the idea that we're going to be able to develop new resources for the current situation, as well as after the initial wave of the pandemic subsides and the public health emergency designation is lifted. Then we're going to be keeping you updated on any of those patient-centered resources that we historically haven't really engaged in the past, just because of capacity. So I'm going to go ahead and pause there, because the next few slides are really just information on the UMTRC, how to get in touch with us, and some of our upcoming events.
Any additional questions at this time? I'm not seeing any.
All right, I'm gonna go ahead and move on then. So we had our first inaugural conference, that was redundant. We had our first conference last year in South Bend at the Gillespie Conference Center, which is adjacent to the campus of Notre Dame. It was a tremendous success, around 100 attendees. And we were expecting to grow that attendance number substantially this year. And it was scheduled tentatively for July 14th and 15th. The decision as to how we're actually going to hold that conference and what material form it's going to take is still kind of in flux. Becky, do you have an update on where we're at when it comes to the conference?
We are still exploring options. There will be at least some form of virtual event taking place. We don't know if there'll be any in-person attendance or not.
Gotcha. I didn't know if we had moved on or not. So if you want to get access to all of our communications, it's not just news articles and upcoming events, but it's also new resources that we find, success stories, things that you might find interesting in terms of being able to implement in your own organization. You can click this link and be added to our mailing list. When it comes to what we do for the region, other than technical assistance and our conference, one of our big outreach events are stakeholder calls that we hold quarterly. They used to be monthly and focus on a different state, but as all 4 states' policies sort of start to converge, we realize that it might just be a more efficient use of people's time in order to just combine all of them. So we've decided that we're having region-wide quarterly stakeholder calls, and our next one is on July 22nd. And if you go to umtrc.org and go to events, you can register for that. It takes a similar form to this webinar that I'm doing right now, but with a little bit more focus on policy and legislative updates. And then finally, if you want to get a hold of any of us directly, these are all of our email addresses. And also, if you have any other technical assistance questions, feel free to use the National Consortium's inquiry module, or even using our website contact form. And our 800 number is listed there, as well as our email address, which is info@umtrc.org. So I'm going to go ahead and put a pin in that and see if there are any additional questions. We are on schedule, so we can either give you a little bit of your day back, or we can answer a few other questions. Oh, and please, I want to direct your attention to the chat, where our other program coordinator, Autumn Daniels, has posted a SurveyMonkey link, which gives us good and valuable feedback, not only for us improving our own webinar delivery, but also for documentation as a federally funded agency.
Thanks, Luke. I appreciate that update. It was very good. So we've got some time. If there's additional questions that you guys have, we can address those. We'll give everybody a minute or two to type in questions. As a reminder, today's webinar has been recorded and it'll be posted on the UMTRC website under archived webinars. We'll have that out in the next couple of days, by Monday or Tuesday next week. I'm not seeing any additional questions. Oh, here's one. You got that, Luke? You're muted.
Yeah, let me go back to that initial slide here. Okay, so yeah, the term telehealth is an umbrella term used to describe any kind of broader definition of distance health activity. And telemedicine is the actual clinical encounter between patient and provider, the billable service. So telehealth itself is not a service; it's a delivery mechanism. So that's what this little Venn diagram is telemedicine. While it fits under the umbrella of telehealth, it's distinct in that it is the actual clinical service being provided.
All right, last chance for questions. All right, well, thank you guys for joining us today, and have a great rest of your day.